Welcome to the final module in the series for Maternal Child Health 2633. This is Module 10 on advocacy, and what I've also done is I've dovetailed health education, which is Module 11, to the conclusion of this module, since I know that very few of you are going to spend any time looking for or listening to or trying to find much information. Hence, the reason we put health education as Module 11 is because it has been embedded in each and every one of the modules that you have undergone. If you note each of the scenarios, there was usually a piece about what was the education to patients, to families, to community. And so you have been interacting with health education throughout all of the modules. Again, we go back to the idea that this is a concept, advocacy, and there was very little reading that you needed to complete for this. I did ask you to look at Chapter 22, which is healthcare across the care settings. Not very important necessarily because you probably will not be working in most of those settings, but it is interesting to note some of the differences. Then I asked you to look for specific information regarding the maltreatment of children. There was a little bit of information in Chapter 3 in the evolving family about sexual abuse in children. And then Chapter 11, we wanted to ensure that you understood the victimization of women, intimate partner violence, and the fact that during pregnancy, physical abuse, sexual abuse sometimes escalates because now you have two victims, not just one, and therefore much more vulnerable. So when we're talking advocacy, we have to remember that as nurses, we're advocates for our patients. And we're going to talk about that now as we go through. In addition to that, I'm going to drop you into the module, which did not happen in Module 9, but it will happen in this module. I want to drop you into the module so we can review it, and you can recognize that there are some other videos there that you might benefit by watching. First of all, we're still talking the pediatrics, so if we're talking about children's or child maltreatment, we can talk about the physical abuse, emotional abuse, sexual abuse, neglect. Anything that endangers a child's physical or emotional well-being, their health, their development. There's a lot of misunderstanding, perhaps, misrepresentation. There's a lot of tattletaling, or trying to cause a problem. That might be part of the reason why our county child endangerment services are so overwhelmed, because not every story is factual, and it takes great investigation tools and techniques to find the truth. Now, we do want to provide the best for all children. We do want to provide a means for safety. We do want to educate families so that they understand what's right and what's wrong, what is over-exuberant conditioning or discipline versus what is laissez-faire. But we also have to have children recognize that this isn't something, it's not a game, and it's not a way to get attention by calling social services or child protective services to alert someone to a problem that now needs to be investigated. Having said all that, though, remember, we as nurses are responsible by law to report. Now, if you're uncomfortable with actually reporting a situation, then we definitely document it very well and contact our supervisors and our charge nurses. And together, we make a plan as to what should and should not be reported. Having said that, also, we want to ensure that with all the cultural diversity that we're seeing, that we recognize that some of the things that happen to children were not done intentionally for pain or discipline or control or maltreatment, but it was done with love and expectation that they would get better. So we have to recognize those things too. We don't want to be too quick to report them as child abuse if indeed it was a medical procedure that had been promoting throughout their ancient history in which to control or change the outcome of a disease. But when we are talking about physical abuse, especially chronic and repetitive, we definitely need to alert that children can be removed from the home, they could be temporarily placed, or they could be watched a lot closer. The family environment would be watched a lot closer. Emotional abuse is much more difficult to identify. What we'd want to be looking for, and teachers probably are at the front line for this, or daycare workers are at the front line so that they can alert someone that there's a change in behavior, a change in activity, a change in lethargy, a change in appearance, a change in response of what appeared to be normal. Another parent might recognize, or an estranged parent might recognize some changes in behavior on children because of an emotional abuse. And so we need to recognize that, be alert to that, and also respond, because we know the emotional and developmental status of a child is just as imperative as their physical growth and development. Sexual abuse, again, looking for the signs, the red flags, the fears, the changes in behavior, the acting out, the regression, just a change from what we would expect to see in normal behavior. The problem with sexual abuse, oftentimes it's kept very quiet because out of fear of retaliation of either themselves or a family member. It's kept quiet because the family member not only threatened but perhaps promised different things. And so we have to find different creative ways to communicate, to allow the children to explain, perhaps to act out by using transitional objects or toys or games or pictures to discover what is really going on. I'm certainly not equipped as a generalized nurse to get to the depth of those things. It would require therapists, or it would require those people who are specialized in how to communicate. And then neglect. We can recognize neglect in any one of our medical units. A child has poor hygiene, malnourished, is living in an environment that might be unsafe, is living relatively alone, doesn't understand or has language skill issues, dental issues. So you can see that at any facility, any unit that you might be working at, especially if you're working in a pediatric emergency department or a pediatric facility where we see kids coming in very rapidly, or an outpatient clinic where we're going to recognize that. School health. Some of you participated in the health screenings this year, and you probably may have noted some of those issues as well. The other big thing that you're going to read about is called Munchausen by proxy. There is a video that's been embedded in your module. It talks about this. I was surprised at the number of students that had never heard this term before, because I thought it was a pretty popular term or well known to people. But it is where a parent or a care provider makes a child ill so that the attention falls to the parent, because they can get attention by bringing their child to the hospital, and oh, poor you, this is awful that this is happening to your child. So they take on a personal responsibility to ensure that the child stays sick, is sick, to the point sometimes of critical illness. And when we remove the parent from the child, we find the child getting better. And then when the child goes home again, the illness begins. And these people that perpetrate physical abuse, emotional abuse, sexual abuse, or Munchausen's are very smart, very cunning, and know to take their children to multiple different facilities. Hopefully this isn't being tracked. But now with electronic medical records, these things are being tracked a lot closer. We can identify it sooner and intervene sooner. So children can be poisoned slowly. Children can be parents can cause hypoxia chronically. Children can be fed inappropriately, be injected with insulin, or be told they have a terminal illness and are given very high doses of medications that are either black marketed, and so children are ill until we take them away from the parent in the hospital setting where we can monitor a little closer. That's why in some pediatric units you will see cameras in each of the sleeping areas, so that we can watch parents as well as children for their safety, but we can also watch parents. And that's part of what you'll see in this video, is where parents are purposely injuring their children in the hospital to keep them sick, so they again are given the attention that they seek, but they're doing it through their children. So it's a rather disturbing diagnosis. And again, the red flag would be when we see multiple admissions for either very vague symptoms or multiple admissions for a problem that seems to get better without any laboratory support or diagnostic support. We do x-rays, we do ultrasounds, we do lab studies, and everything is normal, and yet these vague symptoms or vague syndromes appear. Personally, I've known a nurse who had 3 children. Each children had a very devastating disease. And when I step back now and think about and look at it, I'm wondering if those children didn't have Munchausen's, because I saw the children. They all appeared to be very healthy, normal, well-kept, nutritionally sound children. And yet, according to the parents, this nurse, one child had a severe cardiac disease, one had a severe respiratory disease, and I think one had a severe neurological disease that required multiple visits to neurologists, cardiologists, and respiratory therapists. So again, I didn't know any of the signs or symptoms when I saw the children, but again, I didn't spend a lot of time with them. But when I step back now, I wonder, because she got a lot of attention by us by telling her stories, and we would hear her stories, and of course we would all respond in kind. How do we identify the child that is at risk for abuse? We would want to look for the most vulnerable, the premature baby, the baby that is not perfectly normal, the child with a congenital defect such as Down syndrome, microcephaly, a child of drug abuse, so a baby that was born drug abused, because those babies are irritable and whiny and cry a lot. Babies with failure to thrive are going to be at risk for abuse. Children with any digits or any parts missing or any type of physical anomaly are going to be at a risk for abuse. Children who have a speech impairment or a hearing impairment, a visual impairment, are going to be at risk for abuse. Children of parents who are extremely young, perhaps, or children of parents who are drug or alcohol abusers themselves, or who were abused as children, are at risk. So we need to identify those kids. So we have to ask questions, and we have to find ways to ask the questions that are not pointing fingers or labeling. But we want to identify those so we can help educate families. Let's break the cycles. Let's break the patterns. Let's identify the child. The child that gets moved around a lot, perhaps, might be a little more at risk because they don't ever establish enough information in one community to identify the problem. So nursing care, again, it's family education. We want to start there. Let's provide the parenting classes. Let's provide community resources, support systems. Let's get them into some bona fide group activities where behaviors can be monitored or development can be measured. What about the schools? Let's get families involved with school, and so that they can be helped and watched. Again, supports and referrals. Let's provide the referrals if indeed we do recognize a child that is under the influence of an abuser. Let's get some referrals in there. Let's do our due diligence and report so that the investigation can begin. And again, we are always concerned, and we're very slow to report. We know it's required by us, but we can find reasons not to report because we're afraid of what's going to happen to the child. If we report, investigation starts, what's that parent going to do to the child now? So that's always the risk. That's always a concern. So it is very difficult. I'm not going to say it's easy to pick up the phone and say, hey, I want to let you know that Johnny's getting beat by his dad. I mean, it's very hard to come up with these things. So maltreatment in children is real. It is, but we need to identify those at risk. We need to provide the education we can. We need to do it in a non-judgmental manner. We need to watch the disciplinary practices of our families and our parents when they're in our care. We need to counter those that are very detrimental to children and provide them with better alternatives. Maybe we can just teach them what a better way to handle a situation would be. 2-year-olds with tantrums, what's a better way? 5-year-olds who constantly say no or refuse to do something, or a child that starts to regress. We have to caution our parents that these things are going to happen. Children with chronic illnesses, they're at risk for abuse as well because it gets very fatiguing for parents to always be vigilant with those children. So we need to be alert. How to help children? Okay, we need to help them. We need to help children when they are old enough to understand what their personal boundaries are. What can an adult do or not do to me? Should they be picking me up? Should they be hugging me, kissing me, touching me, helping me dress, helping me bathe, going with me in private vehicles, or going with me to the playground when I'm surrounded by other children? So we need to teach them what personal boundaries are. We need to teach them how to escape, how to make a lot of noise, how not to be friends. Now, that's not to teach children to be afraid of everybody. That is not our goal. But our goal is for them to be aware, not to go with someone they do not know, not to be open to the games of come see the puppy, come see the baby, come see my house, I have lots of dolls, I have lots of toys, I have lots of candy, would you like those? Here's a balloon, if you'll come with me, I'll give you this. So we have to teach them that that's not okay, that they should always get parental permission to participate in any activity, and in that way they stay safe. Not to be alone, they should have buddies whenever they travel somewhere. Develop a trusting relationship with the child. So who does the child trust? Is it a parent, or is it the parent the abuser? Do they trust the school teacher? Do they trust the school nurse? Is there a counselor they can go and talk to? Is there a pastor? Is there a public authority, or an authority of some sort that they feel comfortable talking with? These people need to be identified within the community, and maybe we as nurses can start identifying those individuals to help these kids reach out when they feel like they have nowhere to turn. Their parents aren't hearing them when they're being abused by a family member. The parents aren't hearing them when they feel like they're being bullied at school. The parents aren't hearing them when it's indeed the parent that is the one that's yelling constantly, or demeaning, or detracting from anything good. So we need to help them identify who they would feel safe talking to, being honest with, and open with. That person then has to have the wherewithal to know what to do with the information. Steps in reporting the incidents. Again, many are reluctant to do so. This is something that you will learn in your orientation. We have a collective answer that we know that we need to report. It's a requirement, but who do we report to? When do we report? What information do we need? What is the time frame? How do we document this information? So that is something you'll learn in each facility that you work for, and you would be talking to your supervisor and your charge nurse. So you're a suspect of something, you talk to somebody else. You don't need to do this alone. You don't need to stand out there alone. So that should help you not be so afraid or reluctant to report to help this most vulnerable population. And again, alert children to reach out to the adults that they trust. Sexual abuse and physical abuse. Okay, this is on page 64 and 65. We're stepping back into chapters 3. Usually in a family situation, one child is singled out as the victim. All other family members are kind of left alone. What your book did talk about is that the other parent is kind of a contributor, because if they're not stopping it, they're indeed participating to some degree with knowledge, if nothing else. Sometimes there's a violence for attention. He's choosing my daughter over me as the wife, and so now I'm jealous, which I'll make that daughter's life even more miserable because I'm not getting the attention from my partner that I should be getting. Other family members are usually not threatened until that child is either gone because they've grown up and gotten too old, or because they have been removed from the house, and then it'll start moving down. So there is some survivor's guilt with that as well. So the child has not only been a victim and going through all of that, both psychologically and physically, but now they have some survivor's guilt that I got out what's happening to my siblings, what's happening to my mother, what's happening to whoever else is left in the house, that I'm no longer there for them to act out on. It's going to go to someone else, and you want to try and protect them as well. So there's both of those conflictual thoughts and ideas going on. Nurses are to report to legal agencies or to supervisors if you think there's any sexual abuse, physical abuse. There's been a lot of mainstream attention on sexual trafficking And I think it's a very amazing, some amazing organizations that are working very diligently to put the focus on this, and I think that the focus is helping. Before, I had never even heard of sex trafficking. I probably thought about it in the back of my mind, but it's not something I focused on. It's really become the forefront now that we're talking about it. We're advertising, we're trying to find help for victims, and we're finding out. What I learned over the last year or so was that sexual trafficking doesn't mean that the girls disappear or the boys disappear. They're actually still living in their homes, and the perpetrator has ingraced themselves into the home and has taken this child out and supplied either with drugs, alcohol, and in return they are then sold or bargained off for sexual favors, and yet the child remains in the community. So that was a whole different face to it than I had expected. So again, reaching out to these kids to let them know that this is not acceptable and there are ways out and we can help you, but you have to come forward. But again, they're afraid of what's going to happen either to their other siblings, to their friends, or to their family members. What are the legal agencies or supervisors we would report to? So again, if that's facility specific perhaps, or county specific, state specific, and you will learn those things when you go to work, and that's part of your orientation. Some of the other things we don't always think about is PTSD. We need to think about that as a fallout from some of these behaviors or these problems these children have experienced. So we need to recognize that some of the behavior they might exhibit as a hospitalized patient will be relevant to some of the victimization that they've undergone. So we need to recognize that, and that needs to be part of our care planning, our patient care planning, and how we can provide them some long-term care, therapy or medications or counseling, whatever it will take to help bring them back into a productive life. Had the opportunity to watch Good Will Hunting the other day on a little bit of a break from doing schoolwork, and again it takes you back to how well adaptable children will become and how they learn what is acceptable and unacceptable and how they can move through the system so very well, and you would never have an idea. So if we don't ask the question, we'll never know, and we might be part of a solution if we take the time to ask the questions. Bullying is not in your textbook that I have found anywhere, and yet this again has come to the forefront. It is a word that we banter around quite frequently. We talk about lateral violence, we talk about workplace violence, we talk about bullying, when we talk about bullying though, we usually talk about children, but we see it at all ages, at all places, in organizations, in workplace, in schools, in after-school activities, be they monitored or not monitored. We've heard of bullying even happening when things are being supervised, activities are being supervised. So we need to recognize it as a problem. We need to use the words. We need to educate parents. We need to educate leaders. We need to educate children so they recognize the signs and symptoms and can extricate themselves from the situation. Some people don't even realize they're bullying. Some people don't even realize the impact they might be having. And with social media, it has become even a bigger problem, a much more widespread problem, and we have heard of the horrific results of the suicides or attempted suicides or self-destructive behavior some of these children have had because of the effects of bullying or the social media links. I've put in here one link, that an article that talks about Childhood Safety Network. There's some other articles there that you actually have to open this link and then go to that article and read a little bit more about bullying in the schools, how we can impact it, what nurses' responsibility is, how we should recognize the signs, talk to parents, have parents talk to us about behaviors, and then children, who do they go to? Again, who do they trust to talk to about this? Are they being wimpy by talking about it, or are they standing up for themselves? If they're standing up for themselves, what is the reprisal? How strong are they? And eventually they get worn down, especially when it's a multiple group against you one individual. So we want to help them. So recognize the signs and symptoms first of all. Provide a safe place to discuss the issues with a school counselor. But if I see you coming out of the counselor's office, I know what you were talking about. So we can't have a bullying pen or a bullying office or a safe zone. We have to have a place that anybody could go to for any reason. So like the school nurse, and then call the counselor, and the counselor comes and meets you at the school nurse. Help the parents recognize the signs, again, before it is too late and there's some self-destructive activity that's going on. We find in adolescence, however, that adolescents tend to withdraw somewhat from our parents because nobody understands us, and we're going through such conflict in our own lives that no one can hear us or understand us, so I'm not going to share anything. So my behavior starts to subtly change to the point that there's no return. So we want to help parents recognize and stay communicative with their kids regardless of the age, so that we can stay ingrained in what their lives are about and know what their activities are. And we want to support and advocate and help design and implement programs to promote anti-bullying. And there are lots of schools now that have started some programs, and I know some of the health care providers in those schools or the school nurses are a part of that. We know there are not school nurses necessarily assigned to each school, but they do kind of rotate around. But this is a great avenue for discussions, for assemblies, for projects, not science projects, but for projects to incorporate this thought, this theme, so that we can promote it globally and perhaps have some impact in changing the outcome. So advocacy, your role. Nurses are to advocate for their patients. I said that initially. And this can be a wide variety of things that we can do, and I'm talking about for all ages too, not only for our children, the babies that are drug addicted. We should be the advocate. Watch those parents, talk to those parents, educate those parents. That's being an advocate for that child. The child that comes in abused, advocate for them. The child that is dying, advocate for them. The child who is facing a terrific or horrific surgical intervention, advocate for them. Advocate for your patients. We can't always follow the rule to the letter, and I can't believe I'm saying that, but I think you can read between the lines here. Sometimes we have to find the way that works for an individual patient. So advocate. If you can support what you believe, and you can support it with scientific evidence, or you can support it with knowledge, then I think you'll have a very good the ability to make change. Regardless of what we believe, we must listen to our patients. So we believe that abortion is wrong, and we believe that no one should have an abortion regardless of the reason for the pregnancy. However, we still need to listen to our patients. We still need to provide them medical knowledge, evidence-based knowledge. We cannot impart our own moral codes on everybody. We believe that maybe children should get spanked. And yet we see this child acting out in a restaurant, and we want to go up and tell the parents, would you please control your child? Listen to what the parents say. Maybe this is a child that has autistic tendencies and now is interactive for all of a sudden. So do we want to impede that? So you need to know what the whole story is. So listen to your patients, listen to the families, so that you understand everything that's going on before you make a judgment. If we can educate, we can help them understand the disease, the possible, probable outcomes of their behavior, and promote health. So again, we're always about nursing education, health education, and that is how we can advocate for our patients so that they understand what the risks and benefits of things are. We're not making the decision for them, but we're providing enough information that they can make an informed decision on what they want to do. In the critical thinking class, I remember a very interesting case. A gentleman was going to die, and his daughter wanted him deemed incompetent to make any decisions, and yet he felt he was able to make all decisions and did not want to go into a long-term care facility or assisted living facility. He wanted to go back home, even though he had some pretty devastating physical disabilities that would impede that. But the daughter was that patient had cancer, and the daughter didn't want him to know he had cancer. and we were going to advocate for him to say, you know, he needs to be told this. He needs to be told he only has a few months to live, versus what the daughter wants because she's afraid that daddy will go off on a deep end and start making some very irrational decisions. That's not our call. Our call was to provide care to our patients and find a way to do that without overstepping the law, because at that point the daughter had legal authority over the care of her father. So it was a very diverse ethical dilemma that was presented to the students, and you have all taken that class, and so I think you can recall some of those scenarios that were presented. We must advocate for our patients with the family. They may not understand the changes in behavior of their children or that limitations are real, but we must help them promote productivity, socialization, safety for the continual development. A child has been newly diagnosed with cancer. Put them in a bubble. Don't let them go anywhere. Don't let them participate. We don't want them to get sick. We can't let them be around other kids. They'll get fatigued. They might fall down. They might hurt themselves. It's going to hasten their death. It's going to make the recovery worse. They will be sicker faster. I'm not going to let them do any of those things. So we wrap them up, we put them in a bubble, and we've taken away their quality of life. If we talk to our parents, if we educate our parents, if we allow the parents to listen to the children, then perhaps we can sway them to allow that quality of life. Let them live for as long as they can live, right? That's just one example. A child has a cognitive disorder that maybe was not noted initially, and now we know that they may be bullied, or they may be made fun of at school, or they may not fit in well, and so we retract them from that environment instead of letting them learn how to process it, letting them learn how to interact, letting them learn what the limitations are, which impedes their socialization and impedes their development. So again, educating the parents on, we can help educate others regarding this disease so that your child will not have that same barrier necessarily. Support groups, always a good idea, and most of you are very keen on offering support groups in your discussions when you're promoting health education or you're the advocate for the patient. Parenting classes are a great way to start. Limit setting classes or what discipline is supposed to be about. Allowing choices. Children should be allowed choices, appropriate choices, but again, safe choices. So helping them with support groups, camps, organizational activities that will promote a child's productivity and development. And again, we want to protect the vulnerable groups, and you've identified those groups already earlier when we talked about who's at risk for being a victim of physical, sexual, emotional abuse. So when we roll into Module 11 and we talk about health education, please remember that it has been introduced, or it has been a theme of each one of your modules. Note that education should be at the beginning and end of every patient encounter. You should find out what they know about the situation that you're dealing with at this moment, and then you should be educating them one more piece each and every time. So that way we're not giving them a laundry list, but they're learning a little bit every day so that they can integrate it into their daily lives. To not educate is to fail to do your duty as a nurse, and I feel very strongly about that, and any of you who sat in any of my classes has learned that that's kind of one of my pet peeves, that education is key to what we do. You can teach anybody to give a medication. We can teach anyone to start an IV. I can teach you how to do wound care. I can teach you to do vital signs or ambulate a patient. But I have to want you to participate in the education to allow them to improve the outcome of their health. To educate is not just to tell them what to do, but to help them find a means to incorporate the new knowledge. Telling someone that they have to eat lean, fresh meat for every meal is great because we need to increase our proteins. But running to McDonald's to have a burger 3 times a day is not the way to do it. However, that's all they can afford. But they're not going to share that with you. Yes, yes, yes. So please, we need to ensure that they understand what all this means. And we've got to ensure that we know that they're able to take care of it and be compliant with the care plan that we put forward. And again, remember, it's not a nursing care plan, but it is a patient care plan. We've designed with the patient in mind, so it's individualized for that patient. And again, what I just talked about, be that nutritional changes, activity, posture, substance use, medication administration, wound care, postoperative care, rehab, and or infection control. Each one of those things brings new knowledge, and each one of those things might be added in each time for every patient that we encounter. But they may not be able to be compliant if they are homeless. They may not be able to be compliant if they have no health insurance. They may not be able to be compliant if the only thing they can think about is their next fix. So let's get to know our patients. I guess this all boils down to you need to see your patients, you need to hear your patients, you need to know your patients, and remember that they're very multifaceted. They're not just one entity. They're not just the appendectomy in room 203. Health education has been embedded with each module, each scenario. It's discussed throughout the textbook as well, so you've been inundated with health education. And if you stop to think just for a moment, health education brings us back to health promotion. And health promotion was the very first concept that you were introduced to through this course. So we've completed the cycle. I want to thank you all very much for your attention this quarter. It's been a productive quarter. We've had some ups and downs, but as a whole, I think it's gone very well. We will continue to work to improve the course via your concerns, questions, or considerations. If you have ideas, please put them forward on the final evaluations. If you think there's something that could be detracted or deleted, please put that in your final evaluations. I thank you all. And before I conclude this, as I promised, I would like to be able to step out now and look at the module itself before I get too filled here, which I tend to sometimes do. And now I have lost it again. Found what I was looking for, and this is it, Module 10. I apologize. I'm not going to go through the assignments. Advocacy. Excuse me. Nurses are leaders. I have failed to mention that to you. And we need to recognize that health is recognized as the physical, emotional, developmental, psychological, and spiritual well-being of each multidimensional person. So anything that interferes with their health is what we need to respond to, but we need to find that. Developmental delays or growth might be apparent by observing behavioral changes. Emotional, psychological, and spiritual injury may not be as overt, but may affect the person as greatly as those that can be seen and measured. As advocates for health, we will not know about these injuries or impediments if we do not ask. So it is the standard of care to ask the patient regarding their lifestyle safety. Do you feel safe? Does anyone threaten you? And then what do you do about it? Women and children, we know, are the more vulnerable group and are often the victims of sexual abuse, even young boys. So we shouldn't just say women. It's always about power and control, and it's always that this perpetrator is going to have a behavioral cycle of violence. Please know that you need to know what the cycle of violence is. It's the tension building, the battery, and then the remorse or the honeymoon phase. This is a pattern that is continually over and over again. Now, the times between the battering may get longer or shorter, depending on what is going on in the outside world, but the cycle is always the same. However, in our exuberance to protect and improve the lifestyle, the nurse must be cautious not to victimize this patient again. Having them talk about it again and again without any resolution is not the answer either. Nurses cannot force or expect a patient to be forthcoming or cooperative to my plan, my nurse's plan. You've got to provide support, an attentive ear, and gentle suggestions, but allow the patient to devise the plan that is going to be helpful to them. They know what they can and cannot accomplish. Granted, we could maybe give them a little courage, but we cannot do it for them. Advocacy is not only for the abused patient, but also for anyone that does not have health care appropriately provided to them. Anyone at risk due to culture, gender, finances, age, and illness needs an advocate, and you can help them. Assessments, medications, and health services recommendations Are recommended but limited is the challenge that we now, but the limitation is the challenge we now face. Many aspects of healthcare are not available due to finances. Immunization, health screening, mental health services, nutritional counseling, and cessation programs, though recognized as beneficial, may be too costly for those who need it the most. Nurses are at the forefront to direct the services and case management, specifically designed to coordinate services and monitor expense to assist the patients. In addition to the services provided to improve health, education must be implemented that promotes accountability and self-help. It's all about taking responsibility for myself. I smoked for 40 years. How would I expect not to need therapy at the end of my life? Really? Okay. Consider your family and your own health needs. What barriers have you faced? As a nurse, what changes will you make to ensure everyone has their healthcare needs met? You are a nurse, an educator, and an advocate for all. You must promote health to all, regardless of age, gender, culture, religion, finances, and the presenting illness. Please never say, ooh, I don't want to take care of that. What challenges do you see that will impede this plan? Now think back to the first module, the first week with the introduction to Healthy People 2010, Healthy People 2020. And where will you begin? So again, I wax and wane a little philosophical. Shaken Baby Syndrome is a horrific movie, but it is there for you to look at, to kind of see some of the impact. Discuss with your instructor in clinical what are the healthcare needs of your patient now that they're discharged from the hospital. Did you coordinate that effort? Has it been done by a case manager or a member of the healthcare team? And what about care into a long-term care facility or a chronic needs facility or even a rehab facility, either long-term or temporary? Then this talks about women's abuse and children's abuse. Of course, your ATI and your discussion, which you're not going to participate in the discussion because it is, oh, I'm sorry, this is discussion 10. That's your proctored exam, which we don't want to look at right now. Critical thinking. Munchausen by proxy. Describe what issues would cause you to suspect this issue. So watch the video and then you can answer that question. What is your role in the suspected child abuse issue? Whom would you report the issue to? What communication techniques may provide the child the ability to share feelings with you? And we talked a little bit about that in this presentation. And what safety measures are put in place to prevent further trauma? And that's the key too. We don't want to re-victimize our child. And then of course your two discussions are here for you to participate in. So I'm going to take you back now to the module we had. Oh, we're not going to do that anyway. All right, I'm going to conclude this presentation. There's a lot for you to think about. Again, I waxed and waned a little philosophically, but that's something I have the privilege of doing, a nurse of X amount of years that I've been practicing. So many different things you see, and so many things you hear, so many things you experience, so many things that you may wish you had done a little different, said a little differently. You never have the right thing to say. You never have the right thing to do. So you have to really be thinking through. You first have to explore yourself, though, what you expect, what your limitations are, what you will do, what you won't do, before you can really help someone else. If you have a lot of biases, you're going to have to work through those because you're going to find people with that problem. In fact, you'll probably gravitate to those people because those are your biases. It's rather interesting how that happens. I wish you all well. Next quarter is going to be very exciting for you. You'll be in your preceptorship where you will actually function as the nurse. So I hope things that you've learned here during this course, whether you work in a women's health arena or not, will affect you and help you move towards being the very best nurse you can be. Again, Rasmussen isn't about creating nurses. It's about creating great nurses who have an impact to their hospital, to their care centers, and to their community. So good luck to everybody. I wish you well.